Good morning, everyone. Happy birthday, America. We
Good
hope you're all
morning.
enjoying your summer and your country's 250th birthday party. We're glad that you were able to make it today, and we'd like to welcome you to the Trio Maryland's July Zoom meeting. I'm Marty Marin, and this is my wife, Michelle, and we manage Trio Maryland. We'd like to welcome all our members and guests this morning and thank you for attending. Today's topic is all about cornea transplantation. You will learn all that you need to know right here. Our speaker for August will discuss transplant ethics, so don't miss out on this incredible topic. We're hoping to see all of you there. Now, Michelle will introduce our speaker today.
Hi, good morning. Today's guest speaker is Dr. Jamie Choi, a laser, cornea, and cataract surgeon with the Levin Eye Group. Dr. Choi was recommended by our members Eileen and Jerry Shiat, so thank you both for this recommendation. Dr. Choi is dedicated to improving vision using advanced laser and lens technologies and specializes in comprehensive cornea care. Dr. Choi earned her medical degree from Virginia Commonwealth University and completed her ophthalmology residency at the University of Maryland Medical Center, where she also served as the academic chief. She then completed a cornea fellowship at the University of Maryland, focusing on corneal surgery and transplantation. We are very fortunate to have Dr. Jamie Choi address the Trio Maryland community today. Thank you for presenting to our group. Welcome, and I now turn the program over to you.
Hi, well, thank you so much for having me this morning. And I hope to be able to teach you all a little bit about what I do and a little introduction to corneal transplants. In terms of questions, I did mention that I'll try to answer as many as I can as I go. And then if it's something that I'll eventually get to, it may be addressed later, or we can save them for the end. All right, so some key discussion points I wanted to go over are just the overall function of the cornea, some reasons for why we do a corneal transplantation, what the process of corneal donation looks like, the types of corneal transplants available, risks, benefits, and questions at the end. So overall, what even is the cornea? It's the clear dome-shaped outermost layer of the eye. So it's that window that kind of overlies the iris or the colored portion of your eye. It helps you to focus light to the back of the eye as well as acts as a physical barrier to the inner parts of the eye. And it must remain clear for clear, good vision. So it's kind of like the window of the eye in general. The cornea has five different layers, and you can imagine, how do all these different five layers fit into a cornea that's already so small? You start with the epithelium, right underneath it, there's the Bowman's, and then the stroma, the Descemet's membrane, and then endothelium. And I mention these layers because when it comes to the different types of corneal transplants that we offer, we're actually replacing different layers of the cornea. And a lot of it kind of depends on which layer of the cornea is affected. And then it'll also kind of help determine, possible risks of rejection. I mentioned the endothelium layer here, which is the underlying most layer of the cornea here, and that's kind of what divides the, cornea or the outer eye from the inside of the eye. And so that layer is very integral in the process of rejection. And so if that's something that we can preserve in terms of the host's own endothelium, that risk of rejection goes down a lot. You'll be able to see some of the pictures later from what I mean by that. So overall, some reasons for corneal transplantation. These are just some examples, more common examples, but certainly not limited to this list here. I see a lot of scarring that can be from trauma, from past infections, perforation of the cornea, which is when there is quite literally an opening. There may have been some kind of disease process or trauma that could have caused the cornea to thin, and now you've got some opening and leakage from the cornea. So the inner contents of the eye are now coming out. And some common corneal diseases that I see are one called Fuchs endothelial dystrophy, as well as that of keratoconus. So this is an example of a corneal scar. And so you can see that kind of whitish opacity in the middle of the cornea here, and it's actually overlying the pupil or kind of that opening where we're able to see vision out of. And so, there's really no, medications, eye drops per se that are going to help clear this opacity. And so if this was visually significant and the rest of the eye was healthy, and we can kind of um, estimate that the vision is really impaired by the scar alone, and doing a corneal transplant would be beneficial for this patient. So this is an example of how, a patient with scarring could benefit from a corneal transplant. This is a picture of a perforation, actually. What you're actually seeing here is there's a blue dye or fluorescent dye that we apply to the eye here, and we shine a fluorescent light to it, or blue light to it, and we can actually see the um, aqueous, or the liquid that kind of fills the front portion of our eye kind of leaking out. And so this would kind of be an urgent consideration for a corneal transplant to prevent further leakage. Not doing so would not only harm the eye, but also poses a big infection risk as well. There are, temporizing ways to kind of prevent further leakage, but this patient would be a candidate for like an urgent corneal transplant. So this picture here, this is of the same patient actually. The left picture kind of shows kind of like an overall haziness of the cornea, and then you can kind of see these bullae formation, what we call. Um, on the picture to the right, if you can see kind of that next to the bright beam, you see these kind of spotted little lesions on the inner side of that cornea. And that's what we call guttae. So this is an example of a patient with a condition called Fuchs endothelial dystrophy. It's a genetic condition where essentially the pumping cells of the endothelium of the cornea, they don't work as well. And so, like I mentioned, the cornea needs to be transparent and thin in order for us to have good vision. But if the cells that kind of constantly pump the fluid out of the cornea aren't working as well, the cornea is going to become very swollen, and it'll become hazy over time. And so the main pathology of this condition is having cells on the endothelium, or the inner side of that cornea, that are not working properly. This is an example of keratoconus, which is another very common corneal condition that I see. So on the picture to the left, you can see that the cornea is overall spherical shaped compared to that of the cornea on the right. You kind of see this dome-like, cone-like protrudence coming out from the eye. And what's happening is, over time, the cornea is thinning, and it causes it to kind of protrude into a cone shape, causing what we call astigmatism, which is kind of like an abnormal curvature of the eye. And sometimes with these patients, our average glasses just aren't enough to kind of overcome the amount of astigmatism these patients have. These patients typically need special contact lenses to be able to see kind of at their best visual acuity. But because the cornea can also thin over time, these patients are also at risk of, a corneal perforation, kind of like the picture that I showed earlier. So, like I mentioned, the type of transplant that we offer to patients really depends on the layer of the cornea affected. And they really range from a partial transplant to a full thickness transplant. And they all go by these fancy names and acronyms. But on the picture to the right, you're going to see what's called a PK graft here. It stands for a penetrating keratoplasty. And it's replacing actually the whole of the cornea itself. Uh, the one below that is called a Dulc graft, and it's called a deep anterior lamellar keratoplasty, and it's actually replacing the topmost portion of the cornea itself, kind of as deep as we can, but not crossing the endothelium there. So we're able to maintain the endothelium of the host or the recipient. A DSEC and a DMEC graft, kind of the bottom two grafts, are a little bit similar, but they kind of vary in the thickness. A DSEC graft is able to take a little bit of the stroma or a little bit above the endothelium and the Descemet's layer with it. And I'll kind of explain the reasons for that later. And then a DMEC graft is really trying to just replace the endothelium of the recipient. And we'll kind of go into details a little bit more later as well. So the PK, the penetrating keratoplasty, like I mentioned, is a full thickness graft. And so the process of it is, quite literally, we remove the recipient's diseased cornea kind of in whole, and then we replace it with a donor cornea in whole as well. And so we have these special cutting tools called tree fines where we're able to kind of cut a perfect circle in a sense and remove the diseased cornea. This is all measured prior to actually cutting the tissue itself. And then we replace it with the donor cornea, which is also kind of cut specifically for the patient. And we do this all in the operating room. And so once we're able to make those measurements, we quite literally suture the cornea back onto the recipient. And you can see on this after picture that the diseased cornea has been removed, and you see kind of these sutures radially kind of in the periphery of the cornea that's now been sutured back onto the recipient. The deep anterior lamellar keratoplasty, or the DULC, looks a lot like the penetrating keratoplasty, but you can see on the diagram to the left where a full thickness graft, we're actually removing the cornea as a whole. The DULC is still considered a partial thickness graft, and so we're kind of able to maintain the innermost layer of the recipient themselves. And like I said, that really reduces the chance of rejection significantly. And once we remove that layer, just like the penetrating keratoplasty, we suture the donor cornea back onto the eye. And you might wonder, well, why would we ever do a full thickness graft over a partial thickness graft like the DULC? And so, sometimes when you get patients with a scar, that scar may actually be affecting the entire cornea or every single layer of the cornea. And so doing a partial thickness graft wouldn't be sufficient for a patient like that. And even if we just remove the top portion of that scar, they're still going to have a scar in the undermost lying layer. This graft can actually be very helpful for patients with per se like keratoconus, where they have this natural thinning of the cornea. And then when these patients typically when contact lenses just aren't enough, when glasses aren't enough, and we just can't get their vision clear. Another indication for surgery for these patients would be just contact lens intolerance as well. They just can't really get into the contacts. They're very visually impaired. They can really benefit from a DOLC, and because it's not really like an opacity that's affecting every single layer of the cornea, they can really benefit from a DOLC where we're just kind of replacing that protrusion that they have, and then we can still maintain their endothelium, and then reduce the chance of rejection in the future. And these patients do quite well. So the partial transplants or the lamellar transplants are called DMEC and DSEC. And like I mentioned, it kind of varies in the amount of tissue that's being replaced. And this would be kind of from the innermost part, inner side of the cornea. So DSEC stands for Decimase stripping endothelial keratoplasty. DMEC stands for Decimase membrane endothelial keratoplasty. And so you can see the amount of tissue involved is a little bit different. The DSEC, you're actually replacing a little bit of that stroma here. So you can imagine it's a little bit of a thicker graft compared to that of a DMEC that's shown below. And so you may now be wondering, well, why would you do a DSEC over a DMEC? And it really all comes down to the underlying process again. So when I examine a patient, I'm really seeing how much of the tissue is really involved, and how much of the tissue has to be replaced. And then it also varies in terms of what other eye conditions the patients might have. Kind of a bread and butter standard Fuchs endothelial dystrophy patient where just their endothelium is involved. These patients tend to be very good candidates for just a DMEC procedure where we're really replacing just that inner lining of the eye. However, these patients can really progress to have more swelling than the average Fuchs patient, or they may have had a failed transplant before. And if the complexity goes up there, then they're better suited to receive a DSEC. And they may actually do better with a DSEC. So, you may wonder, well, how do we even remove just one layer or the inner layer of the eye, and how do we replace that? Because it's not like we are opening the whole eye like before. And so what we actually do is we make a very small incision into the cornea here, as you can see. We take what's called a reverse Sinskey hook, and it's like kind of a hook that points up. And with that, we score around these dotted purple lines, which are kind of the measurement of how large how large of a tissue we want to remove. And we score the edges and we kind of strip slowly that inner layer, and then we eventually kind of pull it out of that eye. And then the new graft, depending on the technique that you use, but for the most part, it actually comes rolled up in a little cannula. And that's actually prepared for us from the cornea bank themselves. And so we then insert the cannula into the eye, and then we're kind of able to slowly inject the tissue inside. And then you see this bubble kind of on the third picture. And so part of the aftercare for these patients, they are required to lie flat on their back for approximately 24 to 72 hours. It really depends on the type of gas or air that we use. But you can imagine if you're laying flat on your back, and you're looking up, the air or gas bubble will float up, and it's going to adhere that new donor tissue to your own cornea. And we recommend this positioning kind of as long as it's needed, just to make sure that graft really stays in place. So where do donor corneas come from? The donation process is, so the consent is included with universal organ donor consent. There are eye banks throughout the entire country, and the harvesting occurs within 12 to 24 hours of death. And that's something that I look for when I'm looking at tissues that are potentially submitted to me for my patients. They undergo extensive safety testing. So this includes a wide array of infectious disease panels. We look at the endothelial cell counts, which is, as you remember, the endothelium is the very, very bottom portion of that cornea, and it's really essential to the health, overall health of the cornea. And so, if you think about patients with disease processes that are affecting their endothelium, you want to make sure you're giving them a donor with a healthy endothelium and an adequate enough endothelial cell count. And then the technicians at the eye banks are also assessing the overall quality. So you get things like how thick is the cornea, what's the overall clarity of the cornea. Um, the cornea is interesting that the eye itself is what we consider immune privileged. It's kind of its own little sanctioned organ, and kind of separate from the rest of the body. And so it doesn't need to undergo the same kind of blood matching, like RH matching, like other types of transplants. And it really plays a role in the types of uh, immunosuppression that we give to patients. So it's not, systemic where you're taking, corticosteroids by mouth every single day on top of other immunosuppressing drugs. We actually are able to do this with topical steroids instead. And then overall, the donor is then delivered to me on the day of surgery within 2 weeks of the donor's death. So just a little bit of a diagram. This was taken from the Iowa Donor Network, but I think gives you a good example of kind of the flow of how tissue is received. And so once the eye bank is notified that there has been a death of a registered donor, they procure the cornea within 12 to 24 hours. They do a chart review, make sure there's no any pre-existing conditions that might preclude their corneas from being donated. Then the tissue arrives at the eye bank. It undergoes extensive testing. More chart review is done. And then once it is considered safe for a transplant, one thing that's not mentioned in this diagram is then the surgeon gets a notification of the tissue itself. And as the surgeon, you're reviewing all the testing that's been done. You're reviewing the medical history of the donor themselves. And if you deem that it is an appropriate tissue, you can accept that tissue. And then it is prepared for surgery and then delivered to you for transplantation. So, this is a list of diseases that would absolutely prohibit the use of these corneas. They are mostly limited to things that really affect the like central nervous system. So rabies is one, Creutzfeldt-Jakob disease is also another. But we also include hepatitis B. Retinoblastoma is kind of another malignancy that affects our central nervous system as well. And then again, if the cornea had some kind of infection prior to transplantation, that's not a tissue that we'd want to give to another recipient. Endophthalmitis is another fancy word of saying an eye infection. It's an eye infection that kind of involves the entire eye itself, including the inside of the eye. And then other things that we exclude are patients with HIV, herpes simplex virus, as well as prion disease, which also affects the central nervous system. And then this is also another list of diseases, a lot of kind of leukemias, a lot of kind of disseminated disease, active sepsis, like infection throughout the entire body, dementia of unknown cause, just because you don't know what might be causing it, might be a thing that might be, transmittable or affects the central nervous system again. Down syndrome, you might wonder, well, why is Down syndrome on there? So Down syndrome patients also have a strong association or risk of developing or having keratoconus. And so, sometimes their corneas just aren't, they don't have the, at like the curvatures that would necessarily be ideal for corneal transplantation. And then prior refractive surgery, so patients who've gotten like LASIK or PRK, um, they may not, the tissues may not be used for things like a full thickness transplantation, but it does not exclude their tissues from being used for like a partial thickness or, transplants that require only transplanting the inner layer of the cornea. So this is what the tissue looks like when it comes delivered to me. And so the picture on the left is a picture of a whole cornea itself. And that's what either a PK or a bulk tissue might look like. And that's something that I will cut directly in the operating room with the special tree fines or the cutting equipment to make sure that it's cut correctly for the patient. And then the picture on the right is a picture of a lamellar or partial graft that's come already pre-prepared for me. And like I said, it kind of comes rolled up in a cannula. We connect it to a syringe, and we're able to kind of gently inject it into the eye itself in order to kind of minimize the length of the incisions that we make into the eye. And this is a picture showing kind of how we introduce that tissue into the eye. So you can see that the cannula is introduced into the eye and we kind of slowly inject it. So potential risks and complications, there are so many that we can discuss, but these are probably some of the more common things that we see. We always have to consider the risk of rejection. Overall, it kind of varies between 2 to 20%. And of course, it is higher with the full thickness grafts. And so anytime that we have to replace a patient's endothelium per se, the risk of rejection it just goes up naturally. And then it becomes much higher the more that we have to repeat transplants. The risk of failure for partial thickness grafts, they tend to last about 10 to 20 years, but I've certainly seen patients with them kind of last their entire lifetime. Full thickness grafts, the average lifetime of these grafts are probably closer to 10 years. And then the development of glaucoma. So, glaucoma is a condition that is related to having higher eye pressures, and higher eye pressures can permanently damage your optic nerve. And so, this happens due to the use of needing chronic steroids. A lot of these patients will be on topical eye drops, steroid eye drops for the rest of their lives. And so steroids can tend to increase your eye pressure. And so this is a condition that we look very carefully for. There's always a risk of infection with corneal transplantation, but really for any type of eye surgery or other eye surgery in general. Other things that we're looking for is overall just bleeding. If the patient has not had cataract surgery before, then it might accelerate the formation of a cataract. Retinal detachment kind of comes with having eye surgery in general. There might be some instability in terms of the pressures within the eye, and that can really affect the wallpaper of the eye as well. And then overall astigmatism is something that's really expected, especially with patients with the full penetrating keratoplasties or even a DOLC. We're just not going to have the typical corneal curvatures of someone who's never had a transplant before. And so this is something that we do counsel patients on. We never say, well, you're never going to need glasses or correction, you're going to see so well. It's really so that we're able to improve your vision with glasses and potentially with contact lenses better than what they are seeing now. Overall, the goals of transplantation, again, really depends on the underlying disease process. And like I mentioned, it's not to give you perfect vision, but it's to restore vision back to a point where, better than what these patients might be seeing out of now. And then they will still require glasses and or contact lenses afterwards for their best corrected visual acuity. And that's the end of my presentation. I am happy to answer any questions.
Dr. Choi, that is like mind-boggling to me what you do looking at that. And how did we ever develop all of that to get to this point where you're able to perform these surgeries? I mean, it is just unbelievable looking at that, what you do to help people.
Yeah, it's pretty amazing what we're able to do, and it's part of why I went into ophthalmology. It's because sight is so important, and um it's incredible to see people who have not been able to see for many, many years regain sight. And, most patients are very, very happy for it. And so it's really amazing the work that we're able to do. And I feel very honored to be part of this process, really.
Anybody?
When Marty was waiting to get his transplant and then he had his liver transplant, his eyes were one of the things that really worried me because they were like bugging out of his face. They were very bizarre, and he has had some, eye issues post transplant, and I don't know if other people that are attending, if they've experienced some of those. Now he's been able to manage them, going to professionals like yourself, but I have never known if that was a common situation for recipients that they would then later develop some kind of eye issue, eye strain, eye issue. I don't know if anybody has something to speak to that, or a question, or just to throw that out there. Because you're a very quiet group. I'm very surprised.
Well, I was telling Michelle and Marty earlier that my father had a heart transplant 3 years ago. And I remember just how involved and intensive that whole process is, and the amount of support that we get from a lot of the support groups and really the hospital and the transplant team themselves. But I think one thing that I found was overlooked a little bit was, when you are undergoing some organ transplantation, you are kind of snowed with systemic steroids. And that really affects your whole body. You gain weight, your appetite goes up, you can't sleep. There's so many things that go on. But like I mentioned, people who are on chronic steroids in general, they're at risk for their eye pressures of going up. And my dad also has glaucoma. And so that's something that, we needed to talk separately with his ophthalmologist to make sure that we were monitoring his eye pressures very closely to make sure, it wasn't changing. We weren't risking his optic nerves from being damaged or his glaucoma from progressing. So I remember that was not part of like that whole transplant checklist, but something that, I was very privy to just by my own occupation.
Amazing. Have there been any advancements? My mother suffered from macular degeneration, and in her one eye she couldn't even see the big E in an eye exam, and in the other eye she had a little bit of sight. Have there been any advancements with trying to remedy that once someone has developed macular degeneration?
Yeah, I mean, that can be such a difficult disease to treat. And I'm sure my retina colleagues would have much more information on this, but I have heard of like little retinal like microchip implantations that can help patients perceive the presence of light a little bit more. As far as we know, we don't have like any um, like per se like stem cell therapy or like a nerve transplantation that's necessarily viable right now. Um, and there has been news of someone who has received like a whole eye organ transplant as well. But right now we just don't have the technology to um, restore nerve damage. And so you can replace an organ, but you can't restore the optic nerve or the nerves around it. So, it would be um, you have an eyeball, but you don't necessarily have sight out of this eyeball.
Well, really, thank you. Really fascinating. Thank you for such a detailed explanation of things. The eye, I think, is still a mystery uh, to most of us. And I see Karen just posted
Yeah.
something. My eye pressure went up a lot post-transplant. It was monitored, took 4 months post-transplant to return to normal. And Karen's ophthalmologist is
Hmm.
carefully watching that. Yeah, maybe that is something that a lot of people experience post-transplant, and maybe the steroids has a lot to do with it. And your dad being a heart recipient, he still takes steroids, correct?
He's
He still
actually
takes
been,
prednisone?
I think he's no longer taking prednisone, but he's on other immunosuppressing medications now.
Sure.
Yeah.
Now,
But he was on it for like almost a year and a half. That was a long time.
hmm hmm well, thank you again for your time. Thank you, everyone, for joining us.
Yeah, we
Well,
want to
thank you
thank
for having
everyone for attending today. We always
Mhm.
love seeing everyone's smiling faces. Don't forget to check out our events page on our website for advance notices of our future meetings, and we have a couple coming up here in the fall. Our website is www.triomaryland.org, and all of our past meetings are posted to our YouTube channel for your viewing convenience. Have a great weekend, everyone, and we'll see you in August.
Thank you, Dr. Choi.
Of
Have a
course,
good
my
weekend.
pleasure. Have a great weekend. Thank you for having me.
Thank you. Give the baby kisses.
I will. Thank you.
Bye-bye. Bye-bye.